are more prone for UTI than adults, and this is mainly because of a few anatomical factors and physiological factors. Anatomical factors, UTI is more common in boys in less than 6 months, and that is with malformations of kidneys or vesicular reflux, which is commoner in males in that age. After 6 months, girls take over, and that is because of the urethra, which is the urinary passage, that is quite short, and it is situated quite in proximity with the back passage, which is basically the breeding germs area. And when there is a lack of hygiene, such as back to front wiping, these germs can easily be brought into the front passage and then cause a UTI. And that's why children are having more sort of UTI incidences than the adults. Now, treatment, when you talk of UTI treatment, it depends on, I make a rule of 3. So 3 factors to consider. Firstly, what is the age of the child, whether it is 0 to 6 months or 6 months to 3 years or above 3 years. And what is the location, whether it is upper UTI, that's towards the kidneys and the ureter, which is the kidney tube, or it is the lower UTI, which is bladder or below. And third is what type of the UTI. So whether it is a simple UTI caused by a germ called E. coli, which is the most common and probably more benign, and whether the child responds within 48 hours to the antibiotics, that is simple UTI, or whether it is atypical UTI, which is anything apart from the simple UTI, anything apart from E. coli organism, or the child is not responding to antibiotics within 48 hours, or if the child is unwell. And third is the recurrent UTI, when they are having more than 2 to 3 episodes of urinary infections, one after another. So it very much depends on these 3 factors, and then we decide on the treatment modality, which is mostly antibiotic. It can be given orally or intravenously, and duration varies from 3 days to up to 2 weeks, depending on, again, all the above 3 factors, what modality and duration we choose. And lastly are the investigations. So there are 3 investigations mostly. One is ultrasound of kidney, another one is nuclear imaging called DMSA scan, which picks up kidney scarring, and third is MCUG, which is micturating cystourethrogram. So in that one, we basically put a dye through a catheter in the bladder, and then we check for if there is any urinary reflux going back towards kidneys. So depending on these, then we decide the duration of antibiotic and whether the child is going on long-term prophylaxis or not. If child is having a recurrent UTI or a reflux, then we can put the child on long-term nighttime antibiotics. Finally, the parents and child need to be educated how to prevent urinary tract infection. So they should make sure that there is a regular liquid intake, there is a regular bladder habit, so they empty bladder every 2 to 4 hourly. There is a good hygiene, so I prefer shower every day so that the front part is clean. And finally, taking care of bowel habits, such as preventing constipation, because that can cause a residual urine in the bladder and that can breed the germs.